Hello guys, how are you? Welcome to our channel Last Minute Pharma, your exam antidote. Today we are here with the Pharmacology 2 and we are discussing about the anticoagulants. Okay, in the last lecture we have discussed about the antiplatelet agents, and in this lecture we are going to detailedly understand about the anticoagulants. Okay, so 100% question you are going to get: warfarin, heparin, mechanism of action, the pharmacology of these drugs, and then before going in that particularly in depth, we have to understand first the overview of anticoagulants. Okay, what is anticoagulation? And before understanding anticoagulation, you have to understand what is coagulation cascade. I know many of you have already studied in the first year at HIP what is coagulation, extrinsic pathway, intrinsic pathway. We'll just be revising that a bit, and then we can go ahead with how we are going to stop this coagulation process, or how we are going to interfere in this coagulation process with the help of certain drugs. Okay, so the anticoagulants, just like antiplatelets, I told you, where are we going to use this? We are going to use these drugs when there is an unwanted clot in the blood vessel. Whenever there is an unwanted clot of the blood or unwanted coagulation, that will lead to the blockage, right? And if there is a blockage in the blood vessel, then what is going to happen? Obviously, the blood won't be able to reach to the different parts of the body. So we don't want that, especially in the case of your deep vein thrombosis. We talk about, when we talk about atrial fibrillation, then we talk about myocardial infarction. How do we get myocardial infarction? Nothing but the myocardium cells are going to die. And why are they going to die? Because the coronary arteries which are there, they are not able to supply oxygenated blood to the myocardium. And why? Because coronary artery, there is an unwanted clot formation. There is an unwanted clot formation in STEMI and anSTEMI, and we already discussed that in second year therapeutics. Okay, fine. Now anyways, so what are anticoagulant drugs? Anticoagulant drugs are those drugs which are going to reduce the coagulability of the blood. Okay, so before understanding or before going into deep classification of anticoagulants, different types based on route of administration, we will be discussing about the coagulation cascade. Okay, it's a cascade reaction. So what happens initially? Whenever there is a minor injury, or whenever there is an injury where the blood is going to flow out, and what is going to happen over here? There is going to be two pathways. One is your intrinsic pathway, other one is the extrinsic pathway. Okay, based on the damage, based on the vascular endothelial damage, we are going to divide it into intrinsic pathway and extrinsic pathway. Now, once there is a damage, if we talk about intrinsic pathway, what is going to happen? Your factor 12 which is there, that's going to become into factor 12A. And similarly, in the presence of, see, it's a cascade reaction. What does a cascade reaction mean? Like one after the other. First factor 12 is going to be converted to factor 12A. Then in the presence of factor 12, this factor 11 is going to get converted or is going to get activated, and then in the presence of factor 11A, your factor 9 is going to be converted to factor 9, and then afterwards, if we talk about over here, this is the activated form. The activated form of factor 9, in the presence of this factor 9, the 10 factor which is there is going to get activated. Now this factor 10 which is there, it's a very important factor. Okay. Similarly here also, if you see over here in the extrinsic pathway also, your factor 7 which is there is going to get converted to factor 7A, right? Now in the presence, even it's going to join to the factor 10 itself, and the last is going to join to the factor 10. So now over here, this 10A which is there, this is a very important factor, okay? Because this factor which is there, factor 10, it is responsible for conversion of the prothrombin into thrombin. Try to understand that prothrombin which is there, it is an inactive form. It's in an inactive form. So to activate that or to convert that into thrombin, you need to have this factor 10A. Now, once that's activated, you are having thrombin in the game. Then, to convert this thrombin which is there, it is very necessary for conversion of your fibrinogen, which is nothing but a protein, right? As a plasma protein, fibrinogen to fibrin. Okay, so see, normally in your blood, fibrinogen is there, albumin is there, globulin is there. Yes or no? So, to activate this fibrinogen, you need thrombin presence, and to activate thrombin, you need all these cascade reactions. So once the cascade is started, the thrombin is present, and this in the presence of thrombin, what are we going to do? The fibrinogen which is there is going to convert into fibrins, and these fibrins which are there, they are going to form a mesh-like structures. Okay, for example, there is an injury, so there is going to be formation of mesh like structures. Okay, and in the mesh like structure, what is going to happen? This is what is called as blood coagulation. This is called as your blood coagulation. Now once the blood coagulation happens, what is going to happen over there? After blood coagulation, the platelets are going to come, platelet aggregation is going to come. So to stop the platelet aggregation, we already studied what? We already have studied the antiplatelet drugs. If you don't know antiplatelet drugs, please go to our first lecture, learn antiplatelets, and then you can come back. Okay, now we have understood that antiplatelets, what is the use of that, and now we are going to stop the fibrin mesh formation. Okay, we are going to stop this blood coagulation process. So let us see in deep about the classification of this anticoagulant drugs. What are the different classification based on route of administration, and how are we going to interfere in this coagulation cascade and going to stop this coagulation process. Okay, so now we are going to discuss about the anticoagulant classification. So you have understood what is the normal coagulation cascade process, right? So now we are going to discuss about what are the anticoagulant drugs which are available and how they are going to interfere in this. This is the normal coagulation cascade. Over here, this is normal coagulation cascade, and now we'll see how this anticoagulant drugs are going to interfere with this coagulation cascade. Okay. Now, over here, we are classifying the anticoagulant based on the route of administration. Now, for example, like we are going to have parenteral route of administration, then oral anticoagulants, and then the in vitro anticoagulants. Okay, so just tell you, the oral anticoagulant and parenteral anticoagulant will come under the in vivo anticoagulant. Will come under the in vivo anticoagulant because obviously taking it inside the body, right? That's why it's called it as in vivo anticoagulants. In vitro coagulants, anticoagulants means what? In vitro anticoagulants means they're used outside the body. Now you might be thinking, where are we using it outside the body? Especially when we are going to manufacture blood and blood related products, we need this anticoagulant so that we can prevent the coagulation of the blood. For example, we talk about the blood banks, we talk about, right? And for various tests, when we take the blood, for that also we need to add the anticoagulant. So these anticoagulants which are there, we are going to use in the blood banks. Okay, like heparin, sodium citrate, sodium oxalate, all this category of the drugs which are there, we are going to use it outside the body in the blood bank. Okay, I hope it is clear. Now we are mainly classifying this anticoagulants into two types: parenteral and your oral anticoagulant. Now, if we talk about the parenteral anticoagulant, we are again going to classify a parenteral anticoagulant into two types. That is indirect thrombin inhibitor and direct thrombin inhibitor. So both these parenteral anticoagulants which are available for you, they are going to block they are going to inhibit the thrombin. Now you all can see thrombin over here. Yes or no? You all can see thrombin over here. So if you are going to inhibit this thrombin, if we are going to inhibit this thrombin either directly or indirectly, then what is going to happen? We cannot convert your fibrinogen to fibrin, and if fibrin is not formed, then what will happen? Obviously the coagulation will not take place. Yes or no? So in this way, we are going to block the thrombin. So indirect thrombin inhibitors like heparin, you are having low molecular weight heparin, you are having, then you are having your enoxaparin, then you are having your fondaparinux. So what are all these drugs going to do? They are going to, see again, I'll tell you, the heparin part, if we talk about over here, and warfarin part, we have to discuss a detailed pharmacology of that because that will come in your examination 5 marker. Okay, but now I'll just tell you in very short that indirect thrombin inhibitor means that these drugs which are there, they are going to bind to antithrombin 3. What are they going to bind to? Antithrombin 3. And if they bind to the antithrombin 3, then what is going to happen? They are going to inhibit the thrombin. They are going to inhibit the thrombin. Then various other factors Okay, so now we are going to understand in detail about the pharmacology of heparin. Okay, so heparin, which is there, is nothing but a naturally occurring anticoagulant. Okay, it's naturally occurring anticoagulant. So let's try to understand. So already we have discussed the mechanism of action before, but let's try to understand a bit more in detail. Okay, so what is going to happen? Mainly you're going to have here prothrombin. This prothrombin is going to be converted into thrombin. Okay, in the presence of your factor 10. In the presence of your factor 10. Okay. Now, this thrombin which is there, it is responsible for conversion of the fibrinogen to fibrin. And this fibrin is nothing but the clot, right? Or this fibrin is nothing but going to form the mesh-like structure, which is going to help in the coagulation process. Yes or no? But now, what is the thing? A heparin which is there, okay, heparin which is there, heparin is going to bind with the antithrombin 3. The heparin which is there, it is going to bind or it is going to synthesize with the antithrombin 3. It's nothing but antithrombin 3 is nothing but a serine protease inhibitor. It's a serine protease inhibitor. Okay. So now, once this antithrombin 3 is activated, or once the heparin is going to bind with this antithrombin 3, this is going to show negative, or this is going to inhibit your factor 10, and this is going to inhibit your thrombin. This is going to inhibit two things, factor 10 and mainly your thrombin. Okay, now heparin which is there, mainly we are having two types of heparin. First one which is there, that is your unfractionated heparin, and second one which is there, that is your low molecular weight heparin. Okay, so the unfractionated heparin which is there, that means the molecular weight of the heparin is slightly more. Okay, so what is going to happen, try to understand in case of your unfractionated heparin. Okay, in the case of your unfractionated heparin, it is going to bind with antithrombin 3, and then this is going to bind with the thrombin, this is going to bind with the factor 10, and together which is there, it's going to form a ternary structure. Okay, or you can say it's going to form a ternary complex. And once the complex has been formed, okay, once the tertiary complex or ternary complex has been formed, it is going to efficiently go and block the thrombin, or it's efficiently going to inhibit the activity of the thrombin. This is the case of your unfractionated heparin or high molecular weight heparin. But if I talk about the low molecular weight heparin, what is the thing? What is different between high molecular and low molecular? The low molecular weight heparin which is there, it is preferentially going to inhibit your factor 10. Okay, if we talk about the preference, the low molecular heparin which is there, it is going to inhibit your factor 10 comparatively more than the thrombin. So this is one of the major difference between your unfractionated heparin and low molecular weight heparin. So the low molecular weight heparin which is there, it is preferentially going to go and block the factor 10 compared to the thrombin. I hope the mechanism of action of the heparin which is there, it's clear. So heparin is going to come under the class of what? Indirect thrombin inhibitor. So it is going to indirectly inhibit the thrombin. Yes or no? This drug as such is not going to go and block the thrombin, right? It is going to bind to the antithrombin 3, which is a serine protease inhibitor, and then this serine protease inhibitor or antithrombin 3 is going to go and block or inhibit the factor 10 and your thrombin. I hope till here the mechanism of action of this particular drug is clear to you. Now we are going to understand about the pharmacological action. What are the different pharmacological action? The major ones, if we talk about the major pharmacological action over here, that is the anticoagulant. Anticoagulant action is the major pharmacological action, but whereas the other one, antiplatelet, anti-inflammatory, anti-proliferative and anti-lipidemic, these are some minor pharmacological action of this particular drug. Now, you already saw how was it showing the anticoagulant property, or how was it showing the anticoagulant action by forming or by releasing your antithrombin 3, which is going to inhibit what? It's going to inhibit your factor 10 and then it's going to inhibit your thrombin. Okay, this is how it is going to show the anticoagulant action. But what if I talk about antiplatelet? How is the drug going to show antiplatelet activity? This heparin which is there, it is going to inhibit the platelet aggregation. It is going to inhibit the platelet aggregation, and it is also going to inhibit the recruitment of the new platelets. Okay, it is also going to inhibit the recruitment of the new platelets, and it is going to inhibit the platelet aggregation. I hope it is clear how the drug which is there is showing the anti-platelet activity. Now I am going to talk about the anti-inflammatory property. This heparin drug which is there, okay, the heparin drug which is there, it is having an ability, the heparin drug which is there is having an ability to inhibit, okay, to inhibit the neutrophil. It is going to have an ability to inhibit the neutrophil chemotaxis. Okay, it has an ability to inhibit the neutrophil chemotaxis, and if you inhibit the neutrophil chemotaxis or the neutrophil movements, then what are we doing? We are having an anti-inflammatory effect. We are going to have an anti-inflammatory effect. Is it clear? Then next is going to be anti-proliferative action. This drug which is there, it is going to prevent the proliferation. It is going to prevent the proliferation of smooth muscles. Okay, for example, if we talk about the vascular endothelium which is there, once there is an injury, the smooth muscle which is over there should not proliferate. Why it should not proliferate? Because if that proliferates, it can cause stenosis. What is stenosis? Blockage. Yes or no? If smooth muscle, imagine this is your blood vessel and there's a, I'll just draw it big, yeah. Even this is your blood vessel, there's a small injury and the smooth muscle is keep on proliferating. So if the proliferation is too much, what are we doing? We are indirectly going to block the blood way, right? Or we are going to block the blood passage, right? So that's why this drug which is there, it is going to inhibit, or it's going to have an anti-proliferative action. It's going to inhibit the proliferation of the smooth muscle, and this is going to help in preventing restenosis. This is going to help in preventing the restenosis. Okay, I hope this is clear. Now the last pharmacological action which is over here, that is your anti-lipidemic action. So heparin drug which is there, it is going to activate the lipoprotein lipase enzyme. It's going to inhibit, or it's going to activate the lipoprotein lipase enzyme. And this lipase enzyme which is there, this is responsible for decreasing the triglyceride levels. Okay, this is responsible for decreasing the triglyceride levels in the plasma. So these are the major pharmacological action of the heparin. But those are major ones, but the main thing to remember is of here anticoagulant and antiplatelet property, whereas other properties like anti-inflammatory, anti-proliferative, anti-lipidemic, these all are the minor actions of the particular drug or of the heparin. Okay, I hope the pharmacological action and the mechanism of action is clear over here. Now let us move on to the ADR. What are the various common ADRs which a patient can face after taking the heparin drugs or heparin related drugs? Okay, one of the major one is the bleeding syndrome. Okay, the bleeding is a very common, even in case of antiplatelets we saw, even in the case of anticoagulants we are seeing that bleeding is one of the common ADR of such drugs like heparin. Okay, now next is nothing but hit. Now in this two ADRs you have to remember, you cannot forget, that is bleeding and hit. So whenever you are giving a drug, right, when you are giving heparin related drugs, then the doctors, it's our responsibility that we monitor the bleeding and the parameters, and we observe for hit. What is hit? Hit is nothing but heparin induced thrombocytopenia. It's nothing but the heparin induced thrombocytopenia, and this mainly occurs, okay, this mainly occurs due to antibody formation. This mainly happens, or this mainly occurs due to antibody formation. So I hope it is clear. The bleeding and the hit which is there, it is one of the common parameters which is there, or common areas which are there of the heparin related drugs, and we have to monitor that. Now next, other drugs which are over here, or other areas which are over here, there is your osteoporosis. So prolonged use of such drugs like heparin drugs, it can reduce the bone density. Okay, it can reduce the bone density, and because of that it can lead to a condition which is called as the osteoporosis. Okay, now next area which is there, it is the hypersensitivity. So hypersensitivity means what? After giving the drug, the patient which is there might face urticaria, might face rashes, might face fever, so when any swelling or any rashes near the site of injection. So these are all the hypersensitivity reactions which a patient can face after injecting the heparin. Okay, now the last area which is there, that is the hyperkalemia. See, hypersensitivity, you can remember, rash you can tell, okay, on the site of on the site of injection, then you can, then a patient can develop fever, urticaria, all these things you can remember. Fine. Now hyperkalemia which is there, okay, hyperkalemia which is there, because heparin which is there, it is going to inhibit the aldosterone synthesis. Okay, heparin which is there, it is going to inhibit the aldosterone synthesis. So because of, or aldosterone release, it's going to decrease the aldosterone release. Okay, so if you are decreasing the aldosterone, now what is going to happen? The patient might have a condition of your hyperkalemia. So these are the some areas, major ones which you are supposed to remember is bleeding and HIT. Okay, bleeding which is there, it's a very common area of the heparin related drugs, and HIT which is there is also a very common one. Now next one which is there as a pharmacokinetics of this heparin drug. So heparin which is there, it's a comparatively very polar drug. Okay, it's a high molecular, like molecular weight is comparatively high, and it's a very polar drug. Because of that, we cannot administer this drug orally. Okay, these type of drugs which are there cannot be administered orally. So what do? These drugs are usually administered in the form of IV or in the form of subcutaneous. Okay, then it binds to the plasma protein binding. So because it is going to bind to the plasma protein, then what is going to happen? The plasma concentration, the drug concentration in the plasma, is going to be less. Okay, now next one which is there, metabolism mainly takes place in the liver. Okay, metabolism is going to take place in the liver. There is a special enzyme which is present, that is here heparinase. So with the help of heparinase, the metabolism is going to happen in the liver, and then this drug is excreted via kidney. Simple pharmacokinetics which is having, not well absorbed through the oral route of administration, that's why we are giving through IV or subcutaneous. Plasma protein binding is there, so drug concentration is going to be less in the plasma, and then what is going to happen? Metabolism is going to happen in the liver in the case of with the help of your heparinase enzyme, and then this drug is going to be excreted via your kidney. So this is the pharmacokinetic parameter of the heparin drug. Now the major contraindication which is there of the drug is that the patient who are having severe bleedings, like in the case of, you talk about your ulcers, you talk about, or maybe the patient who is going to have history of HIT. So initially when the patient was given heparin, okay, if the patient has developed a history of heparin induced thrombocytopenia, those kind of patients should not be administered with such kind of drug. Okay, now one more thing you have to understand, in case of overdosing, okay, over here, you have an antidote. Okay, heparin toxicity or overdosing, you have an antidote, that is your protamine sulfate. So in case of severe bleeding which is caused due to heparin or heparin toxicity, then we are going to give you this drug, that is the protamine sulfate. And this is a very important question which can be there in your MCQ questions. Okay, when you're going for higher studies, this kind of questions can come, that for heparin toxicity which drug are you giving, and the answer should be protamine sulfate. Okay, now other thing which you have to remember for the heparin thing is that what are the uses of this heparin. Okay, so mainly for the thromboembolic disorders. Okay, I'll just write down for the thromboembolic disorders. If I write down the uses over here, okay, so mainly we are using this. Okay, mainly we are going to use this for the thromboembolic disorders. Like we can use it in the case of cardiac surgeries like CABG, that is coronary artery bypass graft. Then we can use it prophylactically. Okay, we are using it in the prophylactically in the case of your deep vein thrombosis, you can say, in the case of MI, you can say. So these are all the uses. Where we are going to mainly use the heparin. And if we talk about the in vitro outside, in the case of medical devices, for example, to remove the clot, okay, to remove the clot in the medical devices, we can use this heparin. That is in the medical devices, this is a in vitro application. This is a in vitro application. So these are the uses of the heparin drug. So where are we using? In the case of the thromboembolic disorders, like you see, then you're having a CABG during your surgeries, that's coronary bypass graft. Then we are using in the case of prophylactic treatment of your deep vein thrombosis and MI. Now, this was all about the pharmacology of heparin, a very important 5-marker question. They can ask you what are the mechanism, how does the mechanism of action of low molecular weight and unfractionated heparin differ, and I already explained you that. Okay, that's all very important concepts over here related to heparin. Now let us go towards the one of the very important questions, that is about the warfarin. Let's try to understand this coumarin derivative, that is your warfarin. Okay, so now we are going to discuss about the pharmacology of warfarin. So already we have finished the pharmacology of heparin, and now we are going to discuss about the pharmacology of warfarin. So what is warfarin coming? It's coming under the oral anticoagulants, right? So in the oral anticoagulants, the coumarin derivatives, okay, the coumarin derivative, it's again in MC you will be learning what is coumarin structures and all. Okay, that's not my cup of tea. So they will be teaching about the coumarin derivatives. So coumarin derivatives, you are having one of the drug, let's go warfarin, is going to act as an anticoagulant. So how is it going to act as anticoagulant? Let us try to understand the mechanism of action. So now, mainly in the coagulation steps, we have studied that various factors are involved. Yes or no? Like factor 10 is involved, factor 9, factor 11, or factor 12. All these factors which are there, they are playing a very major role in the blood coagulation process. Okay, but now there are some factors which are dependent on the vitamin K. Okay, so the vitamin K dependent synthesis, like the factors which are there for clotting, they depend on the vitamin K. Okay, so this drug which is there, warfarin which is there, it is going to inhibit this vitamin K epoxidase. Okay, this vitamin K epoxidase. So with this presence of enzyme, try to understand. So mainly your vitamin K is there, the vitamin K epoxidase, to convert it you need oxygen and carbon dioxide. So but for converting vitamin K epoxide to your vitamin K, you are having this, you need this enzyme which is called as vitamin K epoxidase. But now if this enzyme is blocked, okay, if you are going to interfere or you are going to block this enzyme, then what is going to happen? The vitamin K synthesis will be reduced. So if the vitamin K synthesis is reduced, whatever the vitamin K rated products were there, or vitamin K dependent, okay, vitamin K dependent chlorine factors are there, they will not be synthesized. For example, you are having your prothrombin, you are having your factor 10, you are having your factor 8, okay, sorry, factor 7, and then you are going to have your factor 9. These factors which are there, they are vitamin K dependent factors. Okay, they are the vitamin K dependent factors. But now, if the warfarin type of drugs are going to block this vitamin K epoxidase, then what will happen? The vitamin K synthesis won't happen, and because of that, what will happen? The blood coagulation will not take place. So this is a very simple mechanism of action. Okay, let's try to understand the pharmacological action. As it's told, the mechanism of action itself says the pharmacological action. It is going to use as an anticoagulant because it's going to decrease the synthesis of vitamin K dependent clotting factor. Okay, it's going to decrease the synthesis of the vitamin K dependent clotting factors. Okay, now one more thing you have to measure over here, the effect which is there, or the pharmacological action which is there, it should be monitored. Okay, now why I'm telling you this? Because warfarin is having a very narrow therapeutic index. Okay, little bit or slight changes in the dose can also cause a problematic situation. Okay, so clinicians which are there, they have to monitor INR continuously. The INR which is there should be in the range of 2 to 3. Okay, the INR range which is there should be between 2 to 3, and if there is a slight up and down, then the slight adjustment of the dose is necessary. This is a very important thing because warfarin which is there, this warfarin drug is going to have a narrow therapeutic index. It's going to have a narrow therapeutic index. And plus, one more problem with this warfarin drug, okay, one more problem with warfarin drug is that it is having comparatively, one of the disadvantages is that it's going to have comparatively more and more drug interactions, food drug interactions, and many interactions are there. And plus, it's going to have narrow therapeutic index. So these are certain disadvantages of this warfarin related drugs. Okay. So now one important note which you have to understand in the case of warfarin is that the warfarin drug, okay, the warfarin drug is not going to have, the warfarin drug is not going to have any effect, okay, it's not going to have any effect on the existing clotting factor. It is not going to have any effect on the existing clotting factor. Okay, it is just going to degrade the synthesis of the upcoming clotting factors but as such, if the existing clotting factor, the warfarin is not going to have any activity or any action. That's why this warfarin drug, to show the pharmacological or the therapeutic activity, it takes approximately 48 hours. Okay, it takes approximately 24 to 48 hours, and but plus to show the complete effect of warfarin, minimum of 5 to 7 days is required. Minimum of 5 to 7 days is required to get the effective therapeutic activity of warfarin. Are you understanding? Try to understand again. Warfarin type of drug is not going to have any action on the existing clotting factors. Okay, they are mainly going to have the activity on the upcoming clotting factors. That's why the effective time, it usually takes 5 to 7 days to show the particular, or to show the effect to its maximum capacity. So this is one important note which you have to understand about the warfarin. Okay, let us try to understand the pharmacokinetic aspect of warfarin. Warfarin drug, which is there, it is administered through oral route of administration. It is well absorbed in the oral route, but the problem over here is it is highly protein bounded. Okay, especially to albumin, 90 to 99% is protein plasma bounded. So because of that, the volume of distribution is comparatively less. Okay, because of plasma protein binding, the volume of distribution of this drug is comparatively be less. And then if we talk about the metabolism, it's going to be metabolism in the liver with the help of cytochrome 450. Okay, with the help of the cytochrome 450 enzyme. Okay, it's a liver enzyme, right? Now it is excreted mainly through the urine. Okay, this was all about the pharmacokinetic aspect of the warfarin related drug. Now, next is the ADR. What is the major ADR which over here? As I told you, it's talking about the anticoagulants or the antiplatelets. Bleeding is one of the common ADR you can see in a everywhere. In every drug which is there of the anticoagulants and your antiplatelets, bleeding is one of the common area over there. The next one which is over here, that is the skin necrosis. Okay, that is going to be the skin necrosis. So on the early administration of warfarin, the patient can, on the early stage, can have this effect of the skin necrosis. Okay, now next one is that this is coming under category X FDA approved. Okay, like pregnancy, this is going to be a teratogenic drug. Okay, this can cross the placental membrane, and this is like contraindicated in the case of pregnancy. These kind of drugs should not at all be given during the pregnancy stage. Okay, this is coming under the FDA category X drugs for the pregnant women. Okay, the next are the other effects. What are the other effects? It is the nausea, vomiting, and diarrhea. The other effects which can be seen related to this drug is nausea, vomiting, and your headache. These are the common other effects which can be seen on the administration of the warfarin. Okay, so this was the pharmacology of it. Okay, this was the main pharmacology of your warfarin drug. But now, in the case of if we talk about overdosing, what do we do? If there is a mild, if the patient who is there, okay, let's write over here. If the patient who is there is having a mild bleeding, okay, if the patient is going to have mild bleeding, okay, if the patient is going to have mild bleeding or is having a high INR. What is INR? International normalized ratio. Okay, so if the patient is going to have mild bleeding and high INR, we are going to give oral vitamin K tablets. We are mainly going to give oral vitamin K tablets. But now, if the patient who is there is going to have severe bleeding, then very simple, we are going to change this oral tablets to IV vitamin K, followed by infusion of fresh frozen plasma. Okay, what are we going to do? We are going to, in the case of severe bleeding, we are going to inject, or we are going to give an IV form vitamin K, and we are going to infuse fresh frozen plasma with the other clotting factors. So this is the management. Of the, in case of severe bleeding, it is caused by warfarin. Okay, if there is mild bleeding, you can give vitamin K tablets. Okay, and if it's a severe bleeding, we are going to give IV vitamin K, and we are going to infuse fresh frozen plasma with the other clotting factors. And if we talk about the uses, uses are going to be as same as the heparin. Now we have to decide whether we have to give heparin as a drug or warfarin as a drug. Various aspects we have to compare, and then we have to decide whether the patient should be given with warfarin or the patient should be given with the heparin. But the major problem with warfarin is that it is going to have a narrow therapeutic index. It is going to have a narrow therapeutic index, and the clinicians which are there, when you are going to give your warfarin rated drug, the INR should be monitored very closely, and the dose which is there must be adjusted. Now let us have a comparative study. Okay, let us have a comparative study of heparin and warfarin. Okay, let's go ahead with that. Okay, so now we are going to have the comparative study of heparin and warfarin. We have detailedly understood about the pharmacology of heparin and pharmacology of warfarin. Let us try to comparative study and understand about their pharmacological activities. Okay, so if we talk about the heparin and warfarin, if we talk on the basis of their origin, okay, if we talk about the origin, heparin is a naturally occurring, okay, in the procaine use, okay, like in the piglets, we can get this heparin that's naturally occurring, whereas warfarin, which is there, it's a synthetic coumarin derivative. It's a synthetic coumarin derivative. Now, if we talk about its activity, this heparin which is there, it can be used inside the body also and outside the body also. I told you, right? It can be used inside the body, and plus it can be used in the case of the blood banks. I told you, medical devices. I told you. So all this thing it's active in both in vivo and in vitro. Whereas warfarin which is there is only in the case, it's only going to be activated or used inside the body. Next is that the route of administration. Heparin which is there, because of its high molecular weight, high polarity, we cannot give it through oral route of administration, so we mainly give it parenteral. Parenteral means we can give IV or a subcutaneous layer, whereas this drug which is the warfarin is mainly given in the oral route of administration. This is well absorbed in the oral route of administration. Now next, what is the mechanism of action? What is the mechanism of action? This is going to act by activating the antithrombin 3, which is going to inactivate thrombin and factor 10A. But whereas if I talk about the warfarin rated drug, this is going to inhibit the synthesis of the vitamin K dependent clotting factor. Okay, by remember the vitamin K epoxidase enzyme is going to inhibit that enzyme, right? So if it inhibits that enzyme, it's going to inhibit the synthesis of vitamin K dependent clotting factors. Okay, then next, the monitoring parameter. Okay, the monitoring parameter which is over here, we are going to use prothrombin time, the active prothrombin time, for monitoring the activity of heparin. But whereas for monitoring the activity of warfarin, we are going to use here INR, something but international normalized ratio. Okay, but whereas if I talk about the overdosage, okay, if the case of heparin toxicity or heparin overdosage, what do we do? What is the antidote we are having? There is nothing but the protamine sulfate. Okay, but whereas if I talk about the overdosage in the case of your warfarin, what do? We are going to give vitamin K tablets or in the form of IV, and we are going to infuse with the fresh frozen plasma with some clotting factors. Okay, the next is going to be about the therapy. The heparin drugs which is there, it is usually used to initiate the therapy, but whereas warfarin which is there, it is used as a maintenance therapy. It is going to be used as a maintenance therapy. And then if we talk about the case, like if which drug is supposed to be selected in the case of pregnant women, then obviously the option should be heparin, because heparin drug which is there, it is safe during the pregnancy. But whereas warfarin is a teratogenic drug, and this type of drugs should not be given in the case of the pregnancy. Okay, so this was all about the comparative study of your heparin and warfarin. Okay, so by this we finish our lecture about the anticoagulants. We have completely understood about the anticoagulants. We have seen the classification of anticoagulants. We have discussed in detail about the pharmacology of heparin, warfarin, and we also have had a comparative study of this. So this was all for today. Complete anticoagulants in one shot. All the best. Do well in exams. Keep supporting us. Join our Telegram channel. Like our Instagram channel. See, in Telegram channel we are going to soon release the notes for this antiplatelets and anticoagulants too. So okay, do support us. Stay with us. Signing off for today. Thank you everyone. Have a good day.